anytime you like.
Okay, well, thank you, Len. This is Maite de Morena. I have been here in Seattle for almost 2 years. June 1st of 18 is when I started. This is one of the reasons why I came is because over the years, and I've been doing allergy immunology for some time now, but I was a fellow when when Hans described was participated in identifying the genetic basis for the X-linked hyper IgM syndrome, and now in the next hopefully few years we'll start seeing how David Rawlings' group is moving this to a new era of gene therapy and gene correction. So it's a full circle, and I'm excited to be part of it. And this talk is going to sort of tell you a little bit about my journey with this disease, and I'll share those experiences with you and why I became interested. So
Can you speak a little louder?
Get
a little closer to the mic, or speak a little louder.
Can everybody hear me now better? Is that better?
Yeah.
Yeah, okay. Let me just move to the next one. So this is my disclosures. So this is the objectives. I'm going to give you a brief historical background on the X-linked form of hyper-IgM, and I'll share some retrospective data that I collected as part of a multinational study. We'll discuss the long-term survival and outcomes of these patients, and review, in particular, the malignancy complications that I want to bring up to you. Now, I'm going to start with a clinical scenario, and this is a little boy that I encountered, and he was 3 months old and presented with classic manifestations of tachypnea. Was admitted to the ICU. He had received his immunizations. Normally, this is before newborn screening era for SCID, and this was his chest X-ray, and the BAL was significant for pneumocystis. So we were consulted, and these were his immunoglobulins, which you can see here at a 3-month-old, an IgG of 140, which is probably normal, an IgA of less than 7, which can be normal in a 3-month-old, and an IgM of 97, which if you look at the normal values, it's a little on the higher end, but not dramatically elevated. However, the clinical presentation, in particular of the pneumocystis carinii, Jirovecki pneumonia, made us think of the X-linked form of hyper-IgM. The reason I know that many of you see adult patients, but this little boy had a brother who was 12 years old and had been on gamma globulin infusions since the age of 2, managed by an outside physician who had labeled the child as having common variable immune deficiency. So I point that out because, of course, once the brother was diagnosed with X-linked hyper-IgM, we then went back and looked at the 12-year-old, and sure enough, he had the same defect. In retrospect, that little boy had been made, the diagnosis of CVID had been made because of recurrent infections and a borderline and a low IgG with borderline elevated IgM and no IgA, and had not been able to make antibody to vaccines. So in terms of the historical background, this disease was described in the early 60s by Fred Rosen and the group in Paris. And at the time, it was diagnosed as dysgammaglobulinemia because it was trying to in comparison to XLA, where what they saw was that there was a discordance of the 7S gamma globulin and elevated 9-TNS, which represented the IgM at the time. So move forward almost 20 years, and the thought was that this was always a B-cell defect. And it was Lloyd Mayer at the Rockefeller and Henry Kunkel's lab was studying the B cells of these patients. And he had a cell line, which was a accessory cell line, which expresses CD40 ligand constitutively on its surface. And what he did was to mix the cells of the patient, and the patient here is not, the HIV stands for the initials of the patient, not the HIV virus. And what he did was he would mix the patient's cells with his own T cells and the cells from the accessory line. And what you can see is that he was able to allow for these B cells to switch from making IgM to making IgG. And so this was the first clue that that the defect may have something to do with the fact that T cells, that you needed T cells to tell the B cells to switch. And sure enough, it was in the 90s, finally almost 30 years later, that 3 groups reported. In 1993, I was in the middle of a fellowship, reported that CD40 ligand was the defective molecule in patients with the X-linked form of hyper-IgM. And you can see Hans being one of the main contributors to our knowledge, and then subsequently Troy really analyzing the different mutations and cohorts of patients with X-linked type IgM. So, so the hyper-IgM syndromes really encompass a group of disorders that results in defects of isotype switching. And so here there are the classic hyper-IgM syndromes where and I'll show you in the next slide, the X-linked form is more common, but other molecules that are critical for B cell class, for immunoglobulin class switching to occur, represent the autosomal recessive form. But you can see a phenotype of elevated IgM with low IgG and low IgM in many other scenarios, in particular DNA repair defects such as ataxia-telangiectasia, ligase 4 deficiencies, and the mismatch repair system where you have a series of genes that produce proteins that are critical in that DNA repair. And then in addition, there are other immunodeficiencies that again will present with an elevated IgM phenotype and are labeled here. So the importance of understanding the actual molecular characterization, it really provided of this primary immune deficiency, really provided insights into how B cells really are capable of producing antibodies, and really producing antibodies that have high affinity and specificity. And so these mechanisms are class-rich recombination and the somatic mutation. So in CD40 from B cells, which are constitutively expressed on B cells and antigen-presenting cells, will bind to CD40 ligand, which is only upregulated in the setting of T cell activation. And so they will allow for the switching of immunoglobulin isotypes from IgM to IgG and to IgA and E. But at the same time, there is somatic hypermutation, which means that there are specific mutations that are occurring within the variable regions of the antibody molecules that allow for improvement in its specificity. So this is the beauty of really delving into understanding the mechanisms of patients with these defects. You then understand more about the biology of antibody production. So the X-linked form of hyper-IgM is the most common of these disorders. It is X-linked. The gene is the CD40 ligand, and these patients present with a series of recurrent bacterial infections, but importantly, they are susceptible to opportunistic infections. They may have this unique susceptibility to microsporidium. Over 50% of them have intermittent neutropenia, and importantly, they seem to have an increased susceptibility to neuroendocrine tumors. I'm going to show you a little bit about all of these in a second. Now, shortly after the description in '93, this is the first series of patients that were published, about 56 patients, mainly European patients that were compiled. And the survival past 20 years, this is a Kaplan-Meier curve, was dismal. And so that led to, in '95, the first bone marrow transplant offered to these patients. And what you can see in this table here is that as time goes by, the numbers of publications go from, single case reports. This is one of the patients that we had in Florida when I was in my fellowship. But the case series start to increase little by little. And it was not until 2010 and 15 and more recently last year that the larger series of patients of 136, 29, and the more recent one of 130 patients were described, of which larger numbers of unrelated donors were utilized. So, in terms of treatment, there really had been, a push towards transplant for these patients as the only cure for them. So this is where my journey began, and I had this mom came to me here. She was pregnant. She was 7 months pregnant, and she had 3 brothers, 2 of whom had died, and she really never got a chance to meet them because they had died before the age of 10. But this 3rd brother was diagnosed when he was a teenager, and so he was started on therapies that I'll talk about in a minute. And throughout his teenage years was doing great. And so even though at the time, this is the late 90s, people were talking about transplant, he was doing so well that they really didn't want to go to transplant. And so unfortunately in his mid-20s, 20s, he died of a terrible neuroendocrine tumor that was identified in his liver and bile ducts. So this mom came to me. She was pregnant with this little one. She did not know this boy was affected, but she wanted to, establish care so that when this baby would be born, we would test the baby, and if the baby was affected, she wanted to take the baby to transplant as soon as possible. So this baby was born and was affected, and so we went ahead and typed the baby. Now the problem was that mom was of Indian ancestry and dad was of Italian ancestry, and so there were no available donors for this child. And so the question was very, very simple, and that is, what is the long-term survival of a transplant versus non-transplant? And really there had been no real good comparisons at the time, and really nobody had a good understanding of what happens with long-term survivals. And there had been, reports of people being in their 50s and 60s with X-linked hyper-IgM and doing fine. And so this was a very simple, straightforward question. And so thanks to Chaim Roisman, who had coffee with me, and I asked him, so do you know the answer to that question? He said, no, but you should try to answer the question. So that led me to become more interested in this disease. And so I put together a group of individuals from different parts of the world, thanks to the funding through the Jeffrey Modell Foundation and through Maura Cohen's collaborations with PIDTC, and put together a study that had the following objectives. First was to compare the survival time from diagnosis with and without transplant, and for those who had been treated with transplant, investigate what transplant variables influenced survival. So, and in terms of secondary objectives, I wanted to review, the presenting clinical manifestations and how they predicted survival. There hadn't been really any, large series of patients since that initial series that I told you of 56 patients that was published by Levi back in the late 90s. The second was to understand what were the current standard of care. I mean, did everybody get offered transplant? Did everybody get started on prophylactic antibiotics? What type of prophylaxis was being recommended? And if you had neutropenia, were you treated with G-CSF, and for how long? And what was the standard? And third was to try to compare the general well-being and activities of daily life as measured by Lansky and Karnofsky scores. And these are scores that are used very commonly in the transplant population. And this is before, that there were no quality of life studies available. So this was a sort of a indirect way that I thought that we could get some information in terms of quality of life, but really it's more of activities of daily living. So when you do these types of study, you really need to try to do an appropriate power analysis. And so we really wanted to design a study that was to have at least 80% power to detect a hazard ratio. And so what you can see from here is that for samples less than 100, the hazard ratio had to increase in order to be detected. So if you had between 100 and 150 subjects, 100 and 150 subjects, for example, the range, which we thought could be possible in terms of enrollment, we could detect, a hazard ratio of 2 with about 80% power. So what that means is that a hazard ratio of 2 means that, that one group has twice the mortality rate of the other for the duration of the time that you follow these patients. So the study was designed for, a target enrollment of about 200 patients with an assumption that about 40% of them would be transplanted. And so we thought that, a range of between 165 and 200 patients really would give us at least a hazard ratio of 100 and of greater than 1.8 with or without transplant. So that's what we tried to compile. And so this is the number of patients that were entered. And we designed a REDCap database, and we entered 189 patients, of which 176 patients really had complete responses to all of the REDCap questions, and about 13 only had incomplete. So we were left with 176 patients, which was the largest series that had ever been compiled of patients with X-linked type IgM. So in the next slides, I'm going to show you the details of the results. And so what you can see is that in terms of year of diagnosis, we had patients that had been diagnosed from 1964 to 2013. About 77% of them had an established molecular diagnosis. The age-up diagnosis was, the median age was 1, but what you can see here is that there are patients that were diagnosed in their late 60s, and these are, some of Hans's patients, and very similar to many other X-linked disorders. About 40, here about 44% of this cohort had a positive family history. But interestingly, only 8 of them had been diagnosed at birth. Again, this is, I think, a fault on our side that we really don't explain to families the importance of recognizing diseases within the family. The age at last follow-up was 11 years with a range of 1 month to 60 years, and the total follow-up time was anywhere between, was around 8 years of follow-up. So in terms of what were people doing in terms of practice, what you can see is that the majority of patients were started on gamma globulin infusions. About 75% of patients were started on pneumocystis prophylaxis. A very small percentage of individuals were placed on azithromycin prophylaxis, and azithromycin prophylaxis is thought to be effective based on HIV literature in the prevention of cryptosporidium, and so that's why we have it here. So, but the majority of people were not using it. If you had neutropenia, and I told you that about 50% of patients will present with neutropenia, about 45% of them were on G-CSF. Now, in terms of geographic differences in practices here, what you can see, it didn't matter where you were in the world this is, there was really no difference in terms of practices. The only difference really was with transplantation. And so what you can see is 38% of our patients of this cohort had been transplanted. And so this again, the total number of patients was 176, and with a presumption we had thought maybe around 40% would have been transplanted, and sure enough, we had 38%. And yet, in terms of geographic differences in practices, there was differences in practice in terms of transplant, in that if you were living in Europe, the chances were higher that you would be transplanted. In contrast, in North America, and this includes Canada and the United States, does not include Mexico, about 41% of patients were transplanted. And if you lived in South America, only 20% of patients. Now, granted, these are the highest numbers. If you're in the Middle East or in Australia, there's only 2 patients and 10. These individuals had not undergone transplant. So this is the more updated Kaplan-Meier curve now in 2017 compared to the Levi data. And what you can see is the median survival time from diagnosis is 25 years. And so this number here has improved with a survival probability of past 20 years of around 40% versus 20%. But the reality is that this is a disease that continues to have complications, and patients die over time. This figure looks at survival stratified by the year of diagnosis. If you were diagnosed between 64 and 84, between 85 and 94, remember the disease, the genetics of the disease was described in 1993, and in the more modern cohorts of after 2005. And what you can see is that, the majority of individuals were diagnosed between 95 and 2013. But there was no real statistical significance in terms of survival probability. Now, granted, the blue line here seems to separate out, but there's not, from a statistical standpoint, there wasn't a true difference here. Now, this is the fundamental and the punchline, and this is the primary objective, and is looking at survival by transplantation. And what you can see is that if you look at the solid line is the patients that have been transplanted, and the dotted line, that had not been transplanted, and the dotted line are the transplanted patients. These are transplanted patients. These have not been transplanted. This is survival probability, and this is time since diagnosis. And I chose time since diagnosis and not since birth because I think you would be biased by time from birth, because you would, there would be a shift and an increase in survival until transplant, right? If you were looking at this from birth. So if you look at the graph, you can see that the transplant group seems to fare, better during the first 12 years after diagnosis. However, the overall survival did not seem to differ. at all. And so if you looked at the median survival time from diagnosis, it was 25 years for the transplanted group and 20 years for the non-transplanted group. So there is no real difference in survival. Now, what this conveys again is that the cumulative survival decreases steadily with time from diagnosis. But there are a few patients that are followed beyond 10 years when maybe death may be occurring, and so it could have a greater effect on the probability of survival. So if we follow these patients for a longer period of time, that could be the case. Now, so given the improvement in diagnosis and transplantation practices in the last 4 decades, we thought, well, maybe the hazards of transplants may have changed this. And so we did this analysis, which is called a proportional hazard regression of post-diagnosis survival. And the bottom line is that what you can see is that the hazard ratio decreases and goes below 1, which represents statistical difference by between 95 and 2000. After 2000, it starts going up again, but that's really because of the numbers being limited. And so these are your confidence intervals. But certainly, survival after transplantation seems to be better than no transplant during this period of time. Then, in terms of the Lansky and Karnofsky scores, which are the activities of daily living, there was a statistical significance in terms of difference with those that had been transplanted faring better than those who had not been transplanted. However, if you look at the actual median numbers of these activities, it doesn't look like, from a clinical standpoint, they're dramatically different. That said, this is what we found. Now, we looked at many variables to identify which would be the predictors of survival. We looked at the GI tract, and we looked at the respiratory tract. We looked at, hematologic involvement, GI disease in general, CNS disease, failure to thrive, etc. And the most important of all was liver disease. And liver disease was a very important, significant predictor of survival. And this was not only for the this is the whole group, but this is not only for the whole group, but especially in particular for those who underwent transplantation. And this is something that in the more recent publications of focusing on transplant patients as well also showed liver disease being the most important predictor. Now, of all the patients, of the 176 patients, about 20% of them had liver disease. And interestingly, this liver disease was the first manifestation of hyper-IgM in 40% of them. In other words, that and these tended to be older individuals, some young adults and late teenagers, presenting with liver disease. Now, in the studies that Levi had done in Europe, mortality was linked with cryptosporidium. In this cohort of 176 patients, only about 7% of these patients had cryptosporidium. But importantly, cryptosporidium was noted in about a quarter of those patients who had liver disease. And this was noted not only in the older groups like diagnosed before the genetics were identified, but even in modern populations where we understand the disease a little bit better, and we're focused on prevention of cryptosporidium. So to summarize this part, clinical management was similar across geographic locations, except for transplant. The median survival from diagnosis is estimated to be 25 years. There's no difference in overall survival between patients treated with or without transplant. The risk associated with transplant seemed to decrease and favor transplant over non-transplant in the late 90s and early 2000s. And amongst those survivors, those who were treated with transplant had higher median activity scores of daily living. And finally, liver disease was the most significant predictor of overall survival. So I'm going to switch gears, and I'm going to tell you a little bit about the transplant group, which were 67 of these patients. And what you can see is that the majority of these patients underwent unrelated transplants, that most of the transplants were bone marrow transplants, that the majority of, again, underwent myeloablative conditioning, and that 85% engraftment, and that 40% had graft versus host disease, which was acute in almost 70% of them, and less common in the chronic. So this is the Kaplan-Meier curve of survival for the transplant group itself. So the good news is that if you underwent transplant, the estimated survival was greater than 80% at 10 years, with most deaths occurring within the first year of transplant. And so, if you looked at whether when were you transplanted between 96 and 2005, and more, more modern cohorts after 2005, what you can see is that those that had been transplanted in more recent years did better than those that had been transplanted previously. And in terms of why that is, this is, survival by year. So if you were transplanted before 93, meaning before the genetics were identified, certainly there was a significant difference in survival compared to being transplanted after the diagnosis the molecular diagnosis was made. So you really now had a better understanding of the disease, had the genetics to back up the disease, and knew how to manage the disease a little bit better. And these patients were coming to transplant healthier than these patients. In terms of when to take the patients to transplant, so this is less than a year, less than 2 years, less than 5 years, and less than 10 years. And from a statistical standpoint, what you can see is as time goes by, the longer you wait, the higher the chances of complications and poor outcome. And certainly if you look at less than 10 years versus more than 10 years, it becomes statistically significant here, and here at less than 5. And that's true not only for hyper-IgM, but for many other primary immune deficiencies, where if you have evidence of end organ disease, the chances are higher that the outcomes are going to be worse. So to summarize this part, survival after transplant was greater than 80% at 10 years. That transplant survival really improved after we understood the genetics of the disease, that although there was not a statistical significantly lower risk for transplant in more contemporary cohorts, in other words, given the improvement in transplant practices, this seems to have also impacted survival. And age at transplantation did predict survival as increasing with age. And then I didn't show you all the details, but the type of donor, the stem cell source, the conditioning regimen, engraftment, or GVH did not influence survival in this cohort. That said, in the more recent review of 130 patients by the European group, the conditioning regimen of myeloablation was associated with improved survival in contrast to our data. And then finally, liver disease at time of transplant was also a very important predictor of poor outcome. So these were unexpected findings, to be honest with you. And the unexpected findings were that there was no real difference in survival overall between patients treated with or without transplant, and that the other unexpected finding was, despite family history, only 10% of them had been diagnosed at birth. That in terms of clinical practice, 5% were not being treated with gamma globulin, 25% were not being given PJP prophylaxis, and then in terms of survival, that the oldest was 60, had not been transplanted, and was doing well. If you look at mortality rate overall of the disease is about 2.2% per year. So this is not a trivial disorder, and it can be you need to be on your guard constantly. So I'm going to go back to my patient, and this is my little guy who presented with pneumocystis. And so because the brother, who was diagnosed at the age of 12, had done so well on gamma globulin infusions, and there were no, they had another brother, and it was not a matched sibling, and they would have to do a matched unrelated. The parents chose not to go to transplant. And so I followed this little boy for many years, and I had seen him at the age in November, and then in January. I had seen him in November. Physical exam was normal, and I usually do abdominal ultrasounds and check stools regularly for cryptosporidium. And in January, right after Christmas, the mom calls me and says, "Oh, his eyes are yellow." And so on exam, he presented with belly pain, and there was this huge, and I could feel this mass in the right upper quadrant, and the mass was this huge gallbladder that he had. And, tons of imaging studies were done, and you couldn't find a tumor anywhere, but something was really obstructing and was causing this gallbladder to be huge and really be part of, that's what I was feeling when I was examining the kiddo. And so sure enough, when endoscopy was made, he was pursued. He had this ampulla that looked like this, which was abnormal. This is what a normal ampulla looks like, and it was swollen and red and looked obstructed. And sure enough, the biopsies were consistent with a neuroendocrine tumor at the age of 7. So this was, quite disturbing. The child underwent a Whipple procedure and chemotherapy and is doing well. But if you look at mortality in this cohort, what you can see is that if you did not go to transplant, the mortality from malignancy was 27%. And liver failure was another 20. So liver failure and malignancy were the most important causes of death in the non-transplanted group. In contrast, the transplanted group, it was mainly infection and transplant-related complications like occlusive disease, graft versus host disease. But this was very important. And so I've become more and more interested in this. And if you look at the cohort of 176, I'm not sure if you can see this clearly, but what you can see is that of this group 9, which represents about 5%, and that developed some form of malignancy. And this form of malignancy were either gallbladder carcinomas or cholangiocarcinomas or these neuroendocrine tumors. And about 44% of these were neuroendocrine tumors. And the tragedy of it is that all of these patients died, except for these 2. And this is one patient that had a brother who had died in his teenage years with a tumor involving the bile ducts, and this kiddo was found to have some pre-malignant changes in the colon, and so he underwent a bone marrow transplant and is alive and well at the age of 16. And this other patient who developed AML, who underwent transplant as well, and also is alive and doing well. And what is important is that the age, the time between the diagnosis of hyper IgM and the diagnosis of the malignancy can be anywhere between 7 and 20 plus years. So I think this is an important aspect of this particular disease that requires significant, vigilance. That and if you have, a male with who carries this CVID diagnosis and presents with these types of disorder, malignancy in their young teens or young adulthood, anywhere between their 30s and in their 20s and IgM as being the key diagnosis. So how do I treat patients with hyper IgM? I put them all on IgG therapy. I continue, sorry about that. I continue on pneumocystis prophylaxis. I had a teenager who was in his teens and would never follow, his prophylaxis, would get admitted, at least once or twice a year with a pneumocystis pneumonia. I use azithromycin prophylaxis based on the HIV literature for prevention of cryptosporidium. If neutropenic, I do use G-CSF if there's symptomatic with oral ulcers, which is not an uncommon finding. And I partner with the GI folks on a regular basis to have them monitor these patients as well. I type everyone, and we discuss transplant. And in terms of surveillance, the reality is there's not a really good standard of care or a good standard of practice in terms of how to monitor these patients. But I especially in the young children, I do liver imaging with ultrasound at least every 6 months, and then in the adults at least at least once a year. Certainly laboratory studies. In terms of lungs, how frequently do these patients need to be imaged? It's not clear. And in terms of, malignancy, how to monitor, it's not known. And this is an area that I'm particularly interested in trying to see, can we identify biomarkers that would guide us, especially for these neuroendocrine tumors, which are so slow growing, to see if we can identify them earlier. And certainly all of these patients, I recommend genetic counseling so that they can really understand what the disease is and how it impacts their family and other members of the family. And with that, I'll end, and I'm happy to take questions.
Thank you very much, Maite. I have a couple of questions. Maybe I missed it, but did you explain why this is an X-linked disease? The other question I have, you didn't mention at all, but I've always wondered, where does IgD fit into this? Do we make D before we make M? What are the D levels in patients like this, and why do we have IgD at all?
Yeah, so the question of IgD, so as when B cells develop, they express both M and D, and then when they switch, the M and D comes off, and D can be shed, but I don't know the role of D, and so it comes, when there's when it is looped out when they're switching to a different isotype.
So when you class
I've never really understood the role of IgD. We do know that it is, I don't know if it's critical for stabilizing the IgM on the surface, or if it's needed for, it is shed in certain inflammatory diseases, but yeah, I don't know the specific role in antibody production, to be honest with you.
And you say
in terms of this is an X-linked disorder, and I apologize. CD40 ligand is on the X chromosome. Yeah.
Others with questions?
I think if I may, I just wanted to sort of recognize that these patients with hyper IgM may or may not have an elevated IgM early on. So the younger the child, the less likely your IgM is going to be elevated, right? And so I think that when you're making a diagnosis of CVID in a patient that is less than 10 years of age and it's a male, I think you should keep the hyper IgM phenotype in your differential diagnosis and think about this as a possibility.
Hi, this is Sally Newbrow from Bellingham. Question about the Cryptosporidium infections and azithromycin. Why is it used so seldomly? I think you said 8%.
Yeah, because there's no standard of care and it's not well established and it's not well defined, and nobody's done the critical studies of comparisons, right? So there's no standard approach for this, and this is just based on some anecdotal evidence of from the HIV literature. Some people will use it, whether it's effective or not, it's unclear. But if there is any benefit, I will use it.
Thanks.
I have another question. When you were looking at all the parameters of transplant versus not transplant, since the outcome, frankly, I suspect isn't what you were looking for, did you or anybody look at the cost of care of these patients with or without transplant? I mean, that would clearly be a factor if it was more successful.
Yeah, so that's a very important question, and that is that really you can extrapolate it to a lot of the different immune deficiencies, right? If you look at cost of care. However, this was a retrospective analysis, and we were we couldn't answer that question because we really didn't have the sufficient data to even try to approach that. And the healthcare costs in different countries are different, right? But certainly this is an important question, especially as novel therapies develop and gene therapy options are available. I think cost is very important. Most children are covered through different programs. However, as they move into adulthood, that coverage disappears, and people can't afford gamma globulin, and so their health certainly declines over time. We know that with the XLA patients, that many of them, have really endured severe economic burdens with the gamma globulin infusions, and so that is, a question that has been answered for SCID, and one of the major pushes for including SCID in newborn screening, because there were economic studies that really demonstrated that if you identify a child with SCID at birth when they're healthy and then you take them to transplant, the cost as compared to, the constant medical needs and the prolonged hospitalizations before transplant and after transplant due to comorbidities, really did show significant difference. And so that's the only immune deficiency where that has been, objectively looked at. but it has not for many other diseases, including this one.
So the point you're making is with SCID, the analysis, if you diagnose it at birth and you treat it aggressively right then, you save society, you save everybody a lot of money as opposed to delaying the transplant.
Correct.
Right.
Okay, well, it's 8 o'clock. Thank you for listening and for having me.
Thank
Any
you. I
other
want to tell
questions?
everybody on the line, I appreciate you. I asked you on short notice to fill in, and so we would have our sessions going regularly. I appreciate you getting up early and giving us this excellent presentation.
All right, thank you.
Bye-bye.
Bye-bye.